All righty. Maybe I'll go first if that's okay.
Oh, yeah.
All right. Okay, so this is a cool case. This is a 40-something-year-old female who was diagnosed with colon cancer. And on her initial staging, it was like a stage 3. On her initial CT, there wasn't a whole lot in the lungs. There were a few tiny little nodules like this. I mean, 1, maybe 2 millimeters at best, and they were scattered throughout. And statistically they're benign because there's not a whole lot of them. But at that point, there was little. They gave her the benefit of the doubt and treated her locally as well as systemically with chemotherapy with the thought it probably wouldn't make whether there were nodules in the lung or not. And she was doing fine. And then this is a different scan, but about a year or so later, she presented with some new symptoms, and they did another staging CT, and you can see that she developed all these cystic lesions in her lungs. And on first glance, you look at them, they're very irregular, and you might wonder if she had Langerhans cell histiocytosis because they kind of have this dirty look. But she's a non-smoker, and the other problem is with the distribution, is that they do go all the way down to the very, very bottom, which we've seen occasionally with LCH. But with adenocarcinomas in the belly, we always have to consider metastases, and they actually biopsied one of these, and indeed it's adenocarcinoma of the colon. But this is probably the best example of cystic metastases I've ever seen.
Is it a reasonable question to ask whether the appearance was influenced by the treatment, that they might have been more solid?
Well, it's possible, but they weren't ever. She had finished her therapy, so there were no lung metastases at the time. So these are de novo.
Oh.
Yeah. So they actually.
Yeah, they're thin-walled Cheerios, kind of.
Yeah, they just showed up this way. Yeah, it was kind of crazy. So I know we've shown a couple of examples of cystic metastases. Now, this was the follow-up scan. They hadn't changed between this one and the previous one, so they hadn't really filled in or anything like that. Okay, this case is how old is this patient? 52-year-old male with COPD, and it goes way back. Let me see if I can find an old radiograph here. I don't know why it doesn't put them in order. But if we go back to, let's see, 2016 maybe. Here's 2015. And you can see on the radiograph there's volume loss in both upper lobes. And already we can see a pretty irregular cavity in the right apex and maybe one here. And if you just showed me this case, my first thought was this is cavitary sarcoid because it's bilateral symmetric. This is North America. But turns out he does not have sarcoid. He has a long-standing history of Mycobacterium Kanne, which had been cultured. So it tends to act like Mycobacterium tuberculosis on imaging. And now I have some serial radiographs of him, which let me get this out of the way. You can see over time, this is 2017, the cavity in the right upper lobe is expanded. Same with the left upper lobe. And then I'm going to pull up the most recent radiograph, which is somewhere now. Here we go. And you can see the big change is this new mass that is developed in the portion of this right cavity. So it looks like an aspergilloma has developed in the cavity, but really a good look for old sarcoid, but it's not. So Mycobacterium Kanne. Now I do have an older CT. We have not repeated the CT because there hasn't really been a need, but just shows how ugly these cavities are. There's traction bronchiectasis, and just really a lot of destructive lung disease, and on his background of emphysema, which may account for some of the appearance. But they talk about with non-tuberculous mycobacteria, the classical appearance looking like tuberculosis, but this is technically it's non-tuberculous mycobacteria, but M. Kanne I kind of consider in the TB family as far as imaging goes. So I'll send along, I have a bunch of radiographs to send along. They just show sort of the steady progression. I don't have anything really old, so I'm not sure how long this has been going on, but at least for 5 or so years, probably longer than that.
Very interesting.
Yeah. This is just a really pretty example, and I think an important teaching point. So this is an elderly patient. I think she was like 80 something. Has been on amiodarone for a long time, and you can see has a pacemaker in, and presented with new shortness of breath. So with this radiograph, you might consider left heart failure with some lung edema. It's more upper zone predominant, not much in the way of pleural effusion. She had a CT scan of her chest that shows this appearance of sort of geographic ground glass opacity consolidation with a lot of spared lobules in between. So a really good look for an organizing pneumonia pattern of injury. There's some perilobular thickening as well. It does have a little tiny effusion. So when I was talking to the clinician, I immediately asked about amiodarone because I saw the pacemaker, and the response was that she had been on it, but then they did point out that she had recently had her dose increased. So this can happen with amiodarone. You can be on it can be idiosyncratic. You can be on it for a long time. And there may be something with the metabolism. Alternatively, in this case, I think the dose increase, for whatever reason, triggered the immunologic response. And there are case reports as well as acute toxicities from IV injections. And you can see her liver is somewhat dense, which is always a clue to the diagnosis. Not the best amiodarone liver I've seen, but pretty decent. But a good look for OP. And she wasn't acting like she was in left heart failure and wasn't really fluid overloaded. So a good look for that.
Yeah, very much so.
All right, this is just a fun case. I don't have a radiograph. I'm going to try to get one. I'm going to have to call the outside hospital and see if they can send it along, because they sent us the CT. I don't think there's any challenge of what the diagnosis is, but this is a 50-something-year-old man who presented with flank pain, and this was picked up on an abdominal CT, which led to the chest CT at another hospital. And you can see there's this large, huge mass in the right hemithorax. It's very heterogeneous. It's got calcium, and if you look carefully, and I'll change the window, you can see there's areas of low attenuation within it as well. Very sharp margins. But what's kind of cool is that there's these vessels within it that are quite large, and you can see some of them seem to go up along the pleural surface. So maybe some intercostals, but also there's some compressed lung next to it. This is sort of the middle lobe here. There's some vessels running off. And then if you come down to the sort of the cardiophrenic fat, you can see there's this big vessel that goes right into it. And so this was resected via thoracotomy, and the surgeon was kind enough to share his picture with me. I ran into him in the hallway today. It was on his phone. But you can see this is the thing. So it's about, 16, 17 centimeters, solitary fibrous tumor. We're waiting on the final path to see if there's any malignancy, but the original core biopsy was consistent with a solitary fibrous tumor, as is the imaging. And I asked him about specifically where the stalk was, and it was at this mediastinal, sort of where the fat is at the mediastinum. So this is where the feeder vessel was, presumably the stalk. But he said it had parasitized several of the lung vessels as well. So they had to sort of, as they separated out, had to excise some of that. But I think a lot of these collaterals are lung and maybe some intercostal collaterals as well. But this is some lower lobe here coming around. So I think these are actually lower lobe vessels feeding into this big tumor. But this is up there with one of the largest ones I've seen.
Yep.
Jeff, is it in the major fissure or is it below the lung?
It's below the lung. Let me put up a coronal. It pushes up the lung. It's so big. I don't honestly. It's hard to tell anything about this one.
Yeah, because we had a pretty large one recently. Fissure, which is again a good clue to it being a solitary fibrous tumor, since they usually rise.
Yeah, you can see it's right up.
Yeah, that one just looks like it's
right up on the bottom,
just pushing everything out.
It just pushed the middle and lower lobe right up. Okay, and then yeah, I think I'll stop there and let you guys go. All right, who'd like to go next?
I can show 3.
All righty.
Okay, this is a young person. He came here recently as a student from the Philippines, and he had a screening radiograph, I think in the context of a student health center or something like that. And the radiograph was perceived to be abnormal. So let me bring up the lateral projection. And of course, it's not floridly abnormal, but there is opacity ill-defined in the left parahilar region. Really hard to see on the lateral, but it's here just anterior to the fissure down here. I'll make that go away. And on questioning, apparently he was asymptomatic, but on questioning, apparently he did say he had had an illness from which he recovered, he said, involving a cough and a fever, and he was feeling okay. But because of this, he was referred for further evaluation. Not entirely sure why exactly, but they did go to bronchoscopy, and they took some samples of secretions, which revealed M. tuberculosis. So this is Mycobacterium tuberculosis. Apparently they did a CT, which may have shown some findings suggestive of that, but unfortunately I don't have that. And you can see here on the same day, he was diagnosed with AIDS. So he has that viral load, his CD4 count is quite low. So this is the situation where we're supposed to think that in patients with AIDS, and particularly that kind of CD4 count, we shouldn't be surprised when they have a so-called atypical imaging manifestation or presentation. So if typical refers to the pattern of reactivation TB where you have apical lung opacity with cavitation, this is atypical. And atypical also refers to consolidation elsewhere, lymph node enlargement, maybe pleural fluid. But this certainly goes along with what tuberculosis may look like in patients with AIDS. And the other teaching point about this is that we're told nowadays that appearance is atypical. We can't tell whether this is reactivation of a latent tuberculosis or an acquired primary infection of tuberculosis. So a couple of years ago, there was all right. Let me go on to this case. Can you folks still hear me? Okay. Something's bouncing up here. I'm not quite sure why.
And now I can. It was
dropped out for about
froze for a second. I wasn't sure if it was me.
Yeah.
Okay. Looks okay now.
Yes.
All right. So tuberculosis and AIDS. This is a person that was administered to hospital. I'll show you in a moment after an overdose. The patient was in the ICU for some time, intubated at this point in time, and was then discharged. So the time between the ICU stay, which I think was about 6 days, so from about the 8th of July, plus about 6 or 7 days. She was imaged again on August 1, so not too long after that. And she complained of some shortness of breath. And let me bring up the lateral. And the finding here, I'll make this big, is this. So if we look at the trachea, it sure looks odd. It's narrowed, and it almost looks displaced as well. But this is clearly abnormal. So let me show you the next CT on the same day as well. And I think you'll be quite impressed by how narrow this is there. Now, it's really interesting because it's a very nodular kind of narrowing. It involves quite a segment of trachea, and maybe there's a little nodular opacity up there. So this isn't too long after a relatively short ICU stay with quite a lot of narrowing of the trachea. So I'll show you the findings here, a description of the evaluation of it. So there is a right subglottic granuloma, including about 50% of the airway, then a more diffuse 3 centimeter segment of mid-tracheal stenosis with friable tissue there. Didn't permit a balloon initially, did a balloon dilatation, and as you can see right there. So this is an interesting kind of, not literally a histological granuloma, but a kind of a granulomatous or process involving the trachea. I thought this is kind of soon after intubation. So I'm not quite sure what to make of it, but you can see how they treated this right there. Have any of you guys encountered one like this relatively soon after an episode of intubation for some days?
No, that one's pretty. Usually it takes more time than that. That's kind of unusual. You wonder if there was like maybe a traumatic intubation and there was more than just pressure necrosis, but maybe an actual mucosal tear or laceration.
Yeah, maybe this is kind of just granulation tissue that's formed there, and they'll take it off, and maybe she'll do fine. But I was quite impressed by that degree of narrowing. So if I do see her again, I'll let you know. But that's that one. This one is really interesting and rather disturbing. So this is let me get you the age of this person, 53. And he was imaged, you saw the diagnosis maybe there already. So he was imaged and has these nodules. Now, they're everywhere, multifocal, multilobar. Many contain areas of cavitation, very similar in size until we get down here when there's a large opacity, relatively lower lobe. But otherwise, cavitary nodules, and I think we would all begin to think of infection. We would think of GPA, for example, and ask if there's sinus disease or kidney disease for multifocal, multi-lobar opacities like that. So he had a CT, got a biopsy. I don't think there was any hint at what the diagnosis was, but that was negative. And then he went to open lung biopsy, and this is adenocarcinoma. And it's interesting that it's invasive mucinous adenocarcinoma with lymphovascular invasion. I was rather surprised by that. But we certainly can see nodules and cavitary nodules, so maybe I shouldn't be that surprised. You know, there's a whole theory of maybe erogenous spread from one focus to another, or just metastatic multiple tumors that may form, that field phenomenon that people sometimes talk about.
Yeah, Howard,
present like that.
These look more synchronous. I mean, not separate primaries. And also,
yes.
Yeah, another important finding, is the sort of, you can see a lot of like that one on the oblique fissure in the right lower lobe is distorting. It has that desmoplastic look to a lot of these nodules.
Oh, yeah, right there.
Yeah.
Okay.
But you're right. It's a good mimic because it can frequently look like infection. But one thing I've noticed is the nodules often are the margins, other than a little spiculation, are fairly clean. They tend not to have that haze around them that you see with a lot of infections. But it's not perfect finding. Right. And then the distorted airways within also make me think about tumor.
Like that one right there. So there's patent airways, but they're distorted. Yeah, I was quite disturbed by that. But perhaps shouldn't be that surprised. So, yeah, certainly this is one of the presentations of adenocarcinoma. Look at this one. It has cavitation or funny distorted airways going through. There's a bronchus going right through it. Interesting. And some patent bronchi in the larger one here too. All right. Those are my cases, Jeff.
Thank you, Howard. All right, Travis or David?
I don't have anything.
I can go.
All right.
Okay, let me know if my audio isn't working. I'm back at regular campus today, so hopefully it won't be a problem.
Sounds good now.
You guys see a radiograph here?
Yep.
So this was a few months ago, as you can see, it was in February. And this was a radiograph I saw yesterday. And so obviously you can see there's some new findings. This looks normal back there, and I will now focus on yesterday's radiograph. And I think probably the first thing that jumps out is stuff in here, probably stuff in here. And you might think maybe it's pneumonia at first or a parenchymal thing, but then when you notice it starts to extend outside of the confines of the chest and looks a little dense in areas. And at this point, I noticed that there was a shoulder radiographs from last month, which I will pull up. But I will show you first. Look at the corticoclavicular joints here, and there's just a little bit of feathery ossification or calcification below the joints that wasn't present on that radiograph. And so credit goes to one of my MSK colleagues who saw this. This patient had painful bilateral shoulders. And you can see there's this stuff around the joints, and it's on both sides, and it's fairly symmetric, and it's clearly new from a few months ago. And so this patient had a history of immunosuppression, and they raised the question of whether or not this was voriconazole, if the patient was on it. And sure enough, the patient is on voriconazole. So I think this is probably a voriconazole-associated periostitis. And I know we've shown a couple cases. I think, Jeff, you've shown that, or David has. But I think it's pretty symmetric. It all looks like it's soft tissue.
In lung transplants, but I haven't seen, that's when Leif was our fellow. I haven't seen a case in a long time. I wonder if they're more aware of it now and they monitor the dosing.
Yeah, I don't know, but I think that's probably what this is, because they've been on long-term therapy. It's very painful. They actually had it's interesting because I was looking in the chart, and I think this also is the value of the personal communication, between the radiologists, because the person that read this, said there wasn't a fracture or anything. It specifically said there's this stuff that could be related to voriconazole. But then I read the hematologist note yesterday, and they specifically said there were no findings on the radiograph to explain the patient's pain. And so they did an MR of the shoulder yesterday too. And I called them. I was like, I think this does explain their pain. This explains why they have, this as well. That is probably what it is. So,
how does
I haven't seen it in a while.
The lateral projection, Travis, does that show anything interesting?
It shows an effusion, and and the reason they did this radiograph yesterday was because this small left effusion was present on the shoulder MR, and I can't really explain that. I was hoping they'd get a CT just so I could see just so we could see the calcification and whatever, the periostitis, but I don't really have a good explanation for the effusion. But I don't really see much else on the lateral view. I don't know if you do.
No, I'm just trying to get a sense of whether the spine is also abnormal, or are we pretty much looking at rib-related disease?
I think some of it's, I don't know, it's probably just rib-related. So
okay.
So, Travis, what was the immune compromise in this person?
They are immunosuppressed. I don't remember if it was a bone marrow transplant. It was some hematologic malignancy. I can look it up and let you know. I can't remember. I was just putting this together this morning. Okay.
This is a more dramatic case than we've seen before. The other cases that Jeff and I have shown have been not as florid as this. This is amazing.
Huh. So this is just a quick paper I pulled up, but they were just showing in some of these images, like you can do bone scans and you can see pretty extensive involvement. This is both shoulder girdles in this patient. But yeah, we'll see if we're going to get more imaging or if they just stop it, because apparently it should resolve on cessation. I can send out this article too. It's interesting that this was first described early to mid 20th century in patients that drank a lot of wine with fluoride preservatives, because it's the fluoride in the voriconazole that's metabolized, and presumably what incites this in some patients, but clearly not many patients. But so it's presumed fluoride painful periostitis right now, but I think it all fits with that diagnosis. And the patient doesn't have renal insufficiency or anything else that would explain it. Let me see. I'm trying to remember oh yeah, this is a really interesting case. So this came in the other day, and you can see this patient is only 35 years old, and they've had prior median sternotomy. Their heart certainly looks large, and it doesn't really look like it's correctly positioned. There's maybe a little bit of dextroversion here, and so certainly they had some sort of congenital heart disease. So the story is that this patient has a DeGeorge syndrome, had a coarctation repair, which I will show you, and she was driving through San Francisco and had sudden onset of hemoptysis, was able to park her car, but then passed out. And so you can see in the right upper lobe, there's some asymmetric consolidation up here. And unfortunately, we don't have an older radiograph. This was at an outside hospital, and this is the CT. And first of all, you'll note, and David, I don't know, this is part of her native aortic arch, as you can see. And so it's very high. Mm-hmm. And she does have DeGeorge syndrome. So I don't know if she did have if it is a cervical arch. I suspect it might be, but that's not really the important thing here. She had a coarctation, which they treated with a jump graft. So this is the native aorta here, and this is a graft that then anastomoses more inferiorly. And this was done when she was like 15 years old. That's one of many surgeries that she had. And then you can see off of this jump graft, there is this large, irregular or more focal outpouching. And then right here, there's a little tiny blush of contrast. And I think that, whenever, and we've shown cases of infected grafts and whatever, but whenever you have, parenchymal abnormality right next to an aneurysm or a graft, you have to worry about a fistula. And this was undoubtedly the site of her hemorrhage. And I think they avoided bronching her just because this CT was so convincing that she actually had a fistula. You can see it's just this pseudoaneurysm arising from the inferior margin and going right into the affected area of the lung. Now, whether that tiny little blush right there is an active focus of extravasation, I don't know or not. But they, with her status and her continuing to expectorate blood from her lung, they discussed for a long time of how to treat this, but they eventually put a stent in to cover that up. And I think what's interesting now is her right upper lobe is completely collapsed since they put the stent in. And I think it's probably just compression from this aneurysm here, because you can see the right upper lobe collapse, the stent. And then when you look at the CT, her right upper lobe bronchus should be this thing right here, which is just, abruptly, just cut off right there. And you don't even really see much in it, I don't think. But the amount of contrast outside of this thing has decreased. There's still a little bit there, but I don't know. This was a pretty dramatic presentation of a pseudoaneurysm from a graft with a fistula to a bronchus and hemoptysis.
Wow.
But
yeah,
David, you agree? You think this is a native cervical arch, given how high this is?
Yes, indeed. I think so.
Yeah.
Like all
and then I think also she had and an aberrant subclavian. And I guess this is the coarct here that they grafted. It's not really that impressive, but this is the ascending aorta where they put the jump graft. So cervical arch with a coarct here in the setting of DeGeorge syndrome.
Cool.
All right, let's see.
Yep.
Now this one's kind of along the same congenital theme, different disease. There's actually a lot going on here. I'll show you the lateral radiograph and see what you think too. But big pulmonary arteries, centrally, kind of, corkscrew vessels. Certainly looks like pulmonary hypertension. You have some peripheral pruning, big left pulmonary artery, big heart. And I'll show you the lateral view and see if you guys see, in addition to her large pulmonary arteries, there's a fun little finding that I saw in retrospect when I was looking at this, but I'd already seen the CT. And it has to do with her arch, because you can see, and she's probably got a left-sided arch here, but notice what you see, or do you guys see anything on the lateral? I'm curious what your thoughts are.
Is there a big
Is there a pulmonary sling? There's something behind
Are you
the,
saying because of the,
yeah,
right here?
yeah, or some kind of anomalous vessel crossing.
Right. So it's right. It's a little high, but yeah, if it was just a regular left aortic arch, you wouldn't expect the posterior indentation on the trachea. Yeah. So on her, and so this, she's 54. 15 years ago, she was diagnosed with asthma as the cause of her shortness of breath. Clearly, she has pulmonary hypertension, and it looks like it could be, shunt vascularity and an undiagnosed shunt. So here was her CT, and she's got a collection of a bunch of stuff. First of all, she actually has a double aortic arch with a smaller right segment, which is really almost invisible on the PA radiograph. But I think that little thing you're seeing on FOSS was the minor right arch on the lateral view. There's this, like, I think this right here, I mean, not that you would ever say that, prospectively, but I think it's probably what that is.
Yeah.
She also has a little patent ductus arteriosus right here, just a small one. And then you can clearly see that she has pulmonary hypertension, and it looks like from the shunt vascularity. So the question is, where's the shunt? She actually has both a little perimembranous VSD right here, and she has a large secundum atrial septal defect right here. Basically, her interatrial septum is almost absent in that area. And so she has other findings. So she never had asthma, really. And I don't think she had a little bit of narrowing of her trachea, and they actually, when they went in and repaired her ASD and VSD, they also ligated the right aortic arch in order to, help relieve any of this that could have been caused from focal tracheomalacia there from the vascular ring. But
so she has all possible left to right shunts, ASD, VSD, and PDA. She's got them.
Yeah, exactly. The only thing, yeah, and a double aortic arch. So this is like the Kanne rule multiplied times several.
So
yeah, it's like
file. every abnormality is represented in one file.
Right. So she's a walking textbook of congenital shunts. No anomalous pulmonary venous return though. So with a good radiograph. All right, now I got to remember what these other ones are. I'm going to go back to this one because this is one that was kind of which one is it? Not that one. That's the one I just showed you. This one. This case is Jeff. You showed the most recent one of these. What was it? 2 weeks ago now, where we had the bilateral superior vena cava, and like you had the one where the right SVC, as you'll see here. So this lady has bilateral superior vena cava. She was injected through the left, and this was a PE study. But she has a right SVC here, and she has partial anomalous pulmonary venous return here. And this does go straight into the left atrium on right here. And then we have the left SVC, which drains into the coronary sinus and into the right atrium. So, and I had shown the case, but you showed the more recent one of just the what I like to call the crisscrossed superior vena cava. But she's slightly different in that she does have an associated ASD. What's interesting though, it wants to be a sinus venosus ASD, but it's really kind of low, because usually we think about the ASD right up here where the SVC would go into the left atrium or into the right atrium. So this is kind of a variant of those. It's still similar, but this one has the full sinus venosus ASD. It's just a little unusual how low it goes. Yeah, there's almost like this little tunnel.
Inferior subtype, which is much less common.
Yeah, that type.
So it's like it's crisscrossed SVCs plus the sinus venosus ASD.
Right.
And so in her case, it's kind of an interesting management question, because I think what they've decided to do is they're going to ligate her SVC up here. Well, not ligate it, but they're going to essentially cut it here and then redirect it via a graft into the right pulmonary or into the right atrium. And then the more inferior portion that's associated with the partial anomalous pulmonary venous return, they'll just leave like this and then close the ASD down here. So they can kind of fix the shunt in one surgery like that. But yeah, just another variant of our different of our different SVC draining patterns that we've seen recently.
So Travis, what do you mean by crisscross? I mean, is anything cross from right to
no,
left?
it was just that. No, it's just I don't know. I mean, it was because Jeff and I have each had cases where they were just isolated with the right SVC going into the left atrium and the left SVC going into the right atrium. So not, just crisscross in the sense it's right going to left and left going to right, not in any sort of like crossing over each other on the scan.
Okay.
But yeah.
That's very interesting.
All right, let's see. I gotta remember what this one is. Let's see. Oh yeah, this is a case. I'm curious what you guys think, because this is one that Brett Elliker had shown me from the VA, and we both had a similar thought. This is a 65-year-old man, and you'll see he was evaluated for pulmonary fibrosis and referred, and you'll see he's got a little bit of. He's actually the most recent, yeah. So you see he's got some little calcified things in the lower lobe. It almost looks like dendriform ossification in the lower lobes. And then he's got right here, a few on the left. And then he's got some other, just a little smudgier centrilobular nodules, and maybe a little bit of just very mild bronchiectasis in the lower lobes. And Brett and I were kind of thinking the same thing. It's pretty subtle. The guy's fairly symptomatic. I mean, we often think of dendriform ossification in the setting of interstitial lung disease and fibrosis, but we've certainly seen cases where it's isolated. And usually the thing I think first and foremost when it's isolated is a patient that's chronically aspirating. So I'm wondering if you guys would agree that this is probably just like a mild aspiration bronchiolitis with a little bit of bronchiectasis in the lower lobes and just some smudgy little nodules, because clearly there are a few airways in the dependent portion that are a little dilated. And the more you look, you see little tiny centrilobular nodules, some of which are calcified.
Yeah,
I don't know, it's pretty subtle.
I agree,
case,
Travis. I mean, that's a pretty classic location for it. And you look at his esophagus right there; it's got fluid pooling in it.
Yeah, right. And that's another. Yeah, it's a little dilated focally right here. So
I've seen a fair amount of this, ossification or whatever it is, calcification in these chronic aspirators, almost more than I've seen it in pulmonary fibrosis. Now that we kind of think about aspiration so much.
Yeah.
Some of the cases that you showed, though, Jeff really had these long crescentic patches of scarring and stuff like that. This is more sort of at a bronchiolitis level. It doesn't seem to coalesce into the scar tissue that some of your cases had. But
yeah,
I think aspiration is most likely here. I thought maybe you were going to reach for amyloid, but those nodules are usually well defined and peri-airway like these.
Yeah, and I think the bronchiectasis, trying to put it all together, yeah, because amyloid certainly is a reasonable thought with just the calcified things, but I think with everything else,
right?
I just didn't. I mean, we were both trying to come up with anything other than aspiration, and amyloid was certainly one thing that we thought was a stretch, but not really much else. But certainly not fibrosis, because this was called a little bit of fibrosis with traction, but I think it's more just primary bronchiectasis from presumably recurrent aspiration in this case.
Yep.
Okay.
Yeah, I agree.
And then let's see, one more, and I've got to remember. Let's see. Oh yeah, this was an interesting recent case, and again, the pitfalls of scanning too early. So this is a patient who was undergoing a PE study, and you'll see that there's no pulmonary embolism. PAs look okay, but then you notice especially when you window in the left atrium, a little bit of heterogeneity to the contrast, and then as you get into the left ventricle, you have almost a blood fluid level or blood contrast level here. And what's interesting about this one is that he could have a thrombus here, and it's hard to know, except you see there's a little bit of stuff extending anteriorly, and fortunately, and you see a little bit of smoke in the descending aorta as well, just suggesting we're at the early end of the bolus. But this is a good one, at least where they did an abdomen pelvis on a delay, and you'll see just the size of the thrombus that's in the left ventricle. So wasn't all just smoke, that there's actually a thrombus hiding under here that you can clearly see. This guy's had an old MI, which explains the physiology of all this. He has reduced transit time because he's got a reduced ejection fraction leading to the slow flow, and also just the reduced CF causing this thrombus to form. But I thought this was a pretty good example of, you know, where some cases are just, you know, equivocal when you don't have any opacification of a chamber like this.
Do you think there's some fat in the myocardium there too from an apical infarction?
Let's see.
I thought I was seeing some low attenuation, but maybe it's just the non.
You would think that there might be, as we often see, and I think it's just thrombus. So.
And what about?
I think it's interesting too. There's some contrast.
Yeah, there's contrast there. Is it just hanging up? Hanging up?
Yeah.
Is that contrast meaning in the chamber that's hanging up?
I think it is actually in the chamber. In the, I don't think it's just hyper enhancing myocardium, because I think it's kind of like the stuff that's hanging up in the IVC. I think, but I don't know. It's just kind of, it's an interesting look though.
Very interesting.
Yeah, but it's just, I think that maybe one of the clues to suggest that there's a thrombus here is the fact that you do see some contrast going around here. So it's not completely that it's just, you know, not reaching there and you have this, the blood contrast level, but certainly, you know, wasn't willing to call thrombus just based on this alone until you see that. So.
Very interesting appearance.
All right, well, that's it for me for this week, Jeff.
Okay, I've got two quick ones I can show. They're actually related to each other, and then we'll just call it a day. All right, so let's start here. So this is a 53-year-old who was on chemotherapy for chronic lymphocytic leukemia, CLL, and developed some shortness of breath, and they got a chest radiograph. It's right here, and doesn't look terribly exciting. I don't see much going on. They did a CT scan not too long after that, and what is visible is the fact, and this can be challenging, especially to a more novice observer, is that the lungs are diffusely too dense. There's diffuse ground glass opacity. You can see in the left lower lobe there's some stuff in the airways, a little bit of atelectasis associated with it, but overall you have these dense lungs, and a nice example of the black bronchus sign, which can't remember if that was Rick Webb who described that or not, but you shouldn't see airways out this far and this conspicuous. So in someone who's immune suppressed, of course, you know, you'd think about a drug toxicity, but I've not seen one this homogeneous. But the other thing in the differential, of course, is Pneumocystis infection, and this was more on insidious onset, which goes along sometimes more with HIV, but it'd been at least over a course of a week and getting more short of breath, probably as the immune system started to decline from the treatment. So this was indeed pneumocystis, confirmed by stain and PCR, and responded to treatment and went away just fine. Now, in contrast, this is another case. This is a middle-aged woman who presented originally from the outside with a CT that looked like this. I didn't have a radiograph, showing a diffuse lung abnormality, extensive ground glass opacity, and this little cystic space or cavity in the right upper lobe, and some interspersed normal lung. No pleural effusion, wasn't acting like heart failure. And then they, on the workup, noticed the white count was very low, and subsequently it was diagnosed with HIV and pneumocystis infection. So this is pneumocystis as an AIDS-defining illness and presenting. But, and you can see a little bit later, she developed some air complications and has a bunch of subcutaneous gas. She developed pneumothorax. But what's kind of cool is on her subsequent radiographs, you can see this cystic space here. This is one of those, the pneumatocele had gotten bigger and it actually ruptured and given her an air leak. And this was a while ago, but now still has developed subsequently ARDS as a complication of pneumocystis, still has extensive barotrauma, or not barotrauma, but subcu gas, Pneumomediastinum, related to ruptured cystic space. And you know, the older literature hints, I won't say, or suggests that pneumatocele formation may be more common in HIV. I don't think it's a strong association, but we don't see them very often. I've only seen them in HIV patients, but it may be that HIV patients tend to have a more insidious onset, a slower clinical course as their CD4 counts fall, and that they have more time to develop this before they present. And I've seen patients with chronic pneumocystis with the cystic spaces, but usually our transplants and other patients present rather quickly with abrupt onset disease.
Jeff, when you go back to that cystic space, is it one that there's a lot of opacity focally around it, so one wonders if it's a separate a separate infection? Isn't it very attenuating around that cystic space, like something cavitating there?
It is, and that's one thing you wonder. Maybe could there be some
two things going on?
Yeah, or there was some. It's pretty dense in there. Maybe she bled into there. But you're right. Typically, they're very thin-walled for pneumatoceles, but you can see the natural history of it. It has expanded and developed a
That's quite
yeah. So just two cases of pneumocystis, but it's always in my differential for diffuse ground glass opacity in an immunocompromised patient or in someone who at least has a low white count before the immunocompromised state is identified. So it's important to look at that, not just a leukocytosis, but a lymphopenia as well.
Also, as a separate sign, she's got a beautiful example of the so-called double wall sign of Pneumomediastinum, where you can see, in relation to the trachea and left main bronchus, air inside the lumen and outside the lumen, so-called double wall sign of Pneumomediastinum.
And also some air around the aorta as well.
Yeah, there's a lot, of course, yeah. Gosh.
Okay, well, that is it.
Hey, Jeff, I can show two more if you want. I pulled up a couple of others.
Okay.
Let's see. So this actually, you mentioned this in that other case I was showing. This is as you can see, 12-month-old who had some airway issues, and this was done yesterday, but we've actually seen two variations of this recently. So the patient was intubated for the CT scan, and you'll see the aorta looks okay there. There is a small patent ductus right here, but as you see in this case, there is a pulmonary sling with the left pulmonary artery wrapping around the distal trachea and then coming anterior to the descending aorta. Now in this case, the fact that they have a endotracheal tube in place limits it a little, but the trachea here is about 9 millimeters, which for his age is not unreasonable in diameter. But if you notice right below the level of the trachea, that there's severe focal compression of the left of the main stem bronchus and then extending into the left sided bronchus. So there's I guess two forms, if you want to, or two different types of airway abnormalities you can see with pulmonary slings. I think this is probably an example of focal tracheomalacia from the compression itself. And I guess the question is, would you guys agree with that? Just given that you probably do not have complete cartilaginous rings here, given that the airway is a reasonable caliber. I guess that's a question for the audience for this one.
Yeah.
Or do you think it's too hard to?
I don't think you can tell, but
hard to say.
Yeah. So they're going to bronch and see, but I guess but there are, that's one thing to always look for is complete cartilaginous rings, but you can also just have focal tracheomalacia, which certainly this patient has too. It's more severe, right? From the compression.
Travis,
but that was yesterday.
Yeah. If you do a virtual bronch, sometimes it's hard to see the rings. It may be hard in this little kid, but in adults, I've done virtual bronchs to show the rings. It just seems to pick them up better.
Okay.
But it may be too tough.
The endotracheal tube. Yeah. That's why that's what I told the surgeon yesterday. I was thought it was a little frustrating that he was intubated, but that's one. So here's the other one that was from just a month ago now. And this was done elsewhere, but sent to our congenital heart disease, our multidisciplinary surgical conference. And here you can see in this sling that there is clearly similar appearance to the sling, except you'll see the trachea in this one. And it's a little, let's see. And I think it's a little noisy because of the iterative reconstruction. But in this case, it doesn't look like it's as focally involved as it is more diffuse. And this is a very young child, and you'll see that even here that the trachea is only like 3 millimeters. So this one, I think there's no doubt that this is probably going to be complete cartilaginous rings, just given that the entire intrathoracic trachea is so narrowed. And when you get to the extrathoracic trachea, it opens up to about 6 or 7, or 5, 6 millimeters. So I think this is probably one. And again, I did some MIPS or MINIPS, but I wasn't able to do a good virtual bronch in this case. I think the kid's probably too small, but you can see here that once you get into the intrathoracic trachea, that is, I'm guessing this is going to be a complete cartilaginous rings. So I'm curious if you guys agree with that based on this look.
Probably so, given how tiny that is.
Yeah. So both of these I will await surgery and follow up, but we'll know more. But it's always important to look for the complete rings throughout the trachea in these patients.
Does anyone have a feel for how they manage such young kids with that?
So the surgeon was going to do he said he's going to do a tracheoplasty. I think he's going to go basically fillet the posterior aspect of the trachea, and I'm not sure how he's going to reconstruct it, but he seems intent on doing that in this case,
Wow.
if there are in fact complete rings.
Wow.
So, yeah. So, but I'll let you know whenever that gets done. So that's it for me, Jeff.
All right. Thanks, everybody, and talk to you next week.
Thanks, everyone.